Hi everyone, I'm Dr. Nina, mentor, study medic, study MRCOG. So in today's video, we'll be discussing about the topic on pharmacology and one of the most important topic, which is the combined oral contraceptive pills. So I would like to welcome you all to the KickStart series on part 1 MRCOG on the topic pharmacology. Now moving on to the topic. So before going into the proper topic, I would like to discuss about the main topics which need to be covered for the Part 1 MRCOG examination on pharmacology module. Mainly, they would be focusing on the classification of the drugs, asking questions like which class these drugs belong to, or mainly referring to the mechanism of action, their pharmacokinetics regarding the placental transfer of drugs and any teratogenic effects, also regarding the side effects of the drug and mainly indications as well as contraindications. And from referring to the previous recall papers and other questions which have been asked so far, so I have seen that mainly they are asking questions from the antibiotics that can cover upon the penicillin group of antibiotics, the cephalosporins, macrolides, clindamycin, which are the lincosamide antibiotics, tetracycline, sulfonamides, as well as metronidazole, antiviral drugs, including the highly active antiretroviral therapy, the ribavirin, as well as the antifungals, including the azoles, that is a fluconazole, and griseofulvin, terbinafine, anti-malarial drugs too, asking about the prophylaxis as well as the treatment during pregnancy, in different trimesters of pregnancy, antihypertensives, which is very important from the pharmacology module in Part 1 MRCOG, as they can ask about the labetalol, which is a first-line antihypertensive in pregnancy, and asking about the mechanism of action of labetalol, hydrolysine, calcium channel blocker, its side effects and contraindications, maximum dosage, and different scenarios can also be asked. Also regarding the IV infusion of labetalol, the dosage. Then moving on to the anticoagulants, very important, another topic, including questions from heparin, both unfractionated as well as low molecular weight heparin, the thromboprophylaxis, as well as the therapeutic dose of anticoagulation, warfarin, its teratogenic effects, and other direct oral anticoagulants, which can be used during gynecology, patients, when to stop, as well as all those things before procedures. Anti-epileptic drugs mainly focusing on its mechanism of action, as well as the most important is the teratogenic effects of the anti-epileptic drugs, which is the safest. Anti-thyroid drugs, propylthiouracil and carbimazole. Anti-androgens, mainly finasteride, which is a mechanism of action. Anti-emetics, the mechanism of action of different emetics, and which is a first-line anti-emetic, second line as well as the third line. Antihistamines, anti-cancer drugs, mainly asking about the mechanism of action or which class of drugs they belong to or its side effects. Urogynecology drugs, mainly for the stress urinary incontinence as well as for overactive bladder syndrome, mainly which has got medical management. Analgesics, very important, especially for the analgesic pain relief during labor, and regional anesthetics as well as local anesthetics and general anesthetics. NSAIDs, asking about its side effects in pregnancy and also about the mechanism of action. Vitamins, what happens if there is a hypervitaminosis of A as well as other retinoid drugs. Uterotonics, oxytoxics, important, mainly oxytocin, what's the half-life, what's the maximum dosage, and regarding its other side effects. Ergometrin, what's its indication. PGE1, which is misoprostol, PGF2 alpha, which is a carboprostol, as well as PGE2 dinoprostol, mainly used in the induction of labor, and its dosages and side effects. Coming to the contraceptive, which is another main important topic, and we'll be covering a part of it in our today's video on combined oral contraceptive pills. Also, they can ask questions about the progesterone-only pills, especially in the postpartum contraception, emergency contraceptions. Many clinical questions can be asked from that easy topic. And also intrauterine contraceptive devices, implants, has got the lower failure rate, vaginal rings, permanent sterilization methods, male sterilization and female sterilization, other natural methods, the barrier methods, can ask about the classification as well as the components and the mechanism of action, as well as very importantly, the failure rate. So just to give you tips and tricks of the part 1 MRCOG, especially in clinical scenario question, there will be some buzzwords in each questions, like maybe there is catchy word about the trimester of pregnancy, which drug to be given, which drug to be avoided, and also mainly regarding the of the clinical scenario questions. And so it is very important to read the question carefully, completely, analyze it carefully before we jump upon the answers. And some 2 or 3 options may be better fitting for as an answer, but we need to choose a single best answer from the options which are given. And it's always good to go through the recalls and the basics, which is mainly important for the part 1 MRCOG examination, and practice as much SPS as possible and not the theory alone, as well as revision is very, very important. Now, moving on to our today's topic of combined oral contraceptive pills. So to start from the basics, I would like to cover in a systematic manner and which all questions can be asked from this topic, which is an important for the pharmacology module. So starting from the development of the hormonal contraception, so lowering the estrogen dosage. As we all know, the estrogen component mainly in most of these contraceptives, ethinyl estradiol is a main component used. It started with 150 micrograms of mestranol, then slowly decreasing the dosage of estrogen to 50 micrograms of ethinyl estradiol, 35 micrograms, 30 micrograms, 25 micrograms. And the newer versions of the combined oral contraceptive pills includes mainly lower doses of the estrogen component, mainly to reduce the side effects of the estrogen component in the reproductive age women as a contraceptive method. And also, there are preparations available with just 10 to 15 micrograms of ethinyl estradiol. That is the modification which has been going on with the estrogen component, mainly reduction in the dosage. While when we come to the progesterone component, which is the combined oral contraceptive pill, actually it has got 2 components, estrogen component and the progesterone component. So progesterone component, newer generations have been coming mainly in reducing the androgen activity. So that's the main modification which has come with the progesterones. So to start with the first generation, it was norethistron, then the second generation levonorgestrel, then came the gestodine, desogestrel, drospirenone, which has got anti-mineralocorticoid activity as well, and then cyprotironestate, which is mainly used for hirsutism and for the androgenic side effects. So this is ordered by taking in the reducing effects of the androgenic effects. So coming to our first question, which of the following belongs to the second generation progestogens? Among the options, norethistron, levonorgestrel, desogestrel, cyprotironestate. So as we already mentioned, so levonorgestrel belongs to the second generation progestogens, which is important as levonorgestrel is a main component. It can be used for the emergency contraceptive. Regimen is available 1.5 milligram single dosage, the single tablet, which is available for emergency contraception, or it can be used in the Mirena, which is an intrauterine contraceptive system, which is very important. Even it has got non-contraceptive benefits also. And the Mirena has got 52 milligrams of levonorgestrel with 20 micrograms daily release. And these are the main important points with regards to levonorgestrel, and it belongs to the second generation of synthetic progestogens. The first generation includes norethistron, and the second generation levonorgestrel. Third generation is desogestrel and norgestimate. Fourth generation is mainly the drospirenone and dinogest. So, as we mentioned, higher doses of estrogen component have been associated with more adverse estrogenic side effects like nausea, bloatedness, breast tenderness, and also irregular breakthrough bleeding. And high progestogenic activity and low androgenic activity is desirable from a synthetic progesterone component. Desogestrel has a high selectivity to progestogenic receptors and low selectivity to the androgenic receptors. The increase in the HDL-C component in the desogestrel plus ethinyl estradiol combination is consistent with conception. So minimal side effects with 100% contraceptive efficacy and a favorable lipid profile makes the desogestrel and ethinyl estradiol combination the pill of preference. So nowadays, the pill of preference is desogestrel along with that ethinyl estradiol combination. Coming to the next question. How many days of hormone-free intervals are required in a standard regimen of combined oral contraceptive pills? So just to know about, there are basically two regimens available, the standard regimen as well as a titratable regimen. And among the options, 3 days, 5 days, 7 days, 10 days. Yeah, it's a simple, easy question. So the hormone-free interval, which is required for a standard regimen of the combined oral contraceptive pill, is 7 days. So 7 days pill-free period is required to have bleeding to occur, and then maybe we can start upon the new pack. So what are basically the combined oral contraceptives? So they contain low doses of two hormones like estrogen as well as progesterone, and the types can be either monophasic, biphasic, triphasic. So monophasic, they have got consistent dose in each active pill, while the biphasic and triphasic, the doses of both estrogen as well as the progesterone component, it varies throughout the cycle. So what is the other classification? It can be either high dose, low dose, or ultra dose. And this dosage classification is mainly depending upon the estrogen component. And the progesterone classification mainly from the different generations and its androgenic activity and its other effects which the progesterone has got. So the high dose of progesterone is mainly if it has got more than 50 micrograms progesterone, it is the component for the mestranol to start with. Then slowly we evolved with lower doses of estrogen to reduce its side effects, and the commonly used is the ethinyl estradiol in most of the oral contraceptive pills have got 30 to 35 micrograms of ethinyl estradiol. There is something which is the ultra low dose, which is less than or equal to 20 micrograms of estrogen. Then coming to about the pills per pack. So if 21 days we give the pill, all active pills have to be given, and then it should be followed by 7 days of pill-free interval, that is, which is seen in the standard regimen. And there are other tailored regimens as well, whereas there is something called as 28-day pill cycle, wherein we give 21 days of active pills and 7 days of inactive pills. Maybe sometimes the 7 days we use to give supplements like iron tablets for the supplementation. And we don't give any break in between peaks, in between the packs. So that is a 28-day cycle. So standard is always a 21-day cycle followed by the 7 days of the pill-free interval. So these are the regimens which are available, the standard regimen and the tailored regimen. The standard regimen, which is commonly used, active pills are given for 21 days followed by 7 days of hormone-free interval. And the tailored regimens can either be shortened hormone-free interval, wherein we give the active pill for 21 days and then followed by only 4 days of hormone-free interval. Then comes the tricycling, where active pills are given for a continuous stretch of 63 days, and then it is followed by 4 to 7 days of hormone-free interval, so that if the person has got some problems like dysmenorrhea, spasmodic dysmenorrhea, or heavy menstrual bleeding, or any problems during the periods, that can be reduced by giving continuous stretch of this active pills and then reducing or maybe the standard hormone-free interval period of 4 to 7 days. Then there is something called flexible extended regimen, where active pills can be given for more than 21 days, and this is followed by 4 to 7 days of hormone-free interval, followed by continuous regime, where continuous active pill taking is allowed. Coming to the next part, which is a mechanism of action, which is very important part. Which of the following contraceptive acts by inhibiting ovulation as its primary mode of action? So levonorgestrel, norepinephrine, etinadiol, as well as desogestrel. So it is basically the the desogestrel, which has got its main mechanism of action by inhibition of ovulation. And the other progesterone has got other mechanism of actions like thickening of the cervical mucus, causing a hostile environment in the endometrium, preventing the endometrial implantation. So, but it's desogestrel which has got the primary mode of action is ovulation inhibition. So coming to about the mechanism of action, the estrogen mainly it suppresses the release of the FSH from the anterior pituitary, and as a result, it inhibits the development of the dominant follicle. It stabilizes the endometrium and minimizes the breakthrough bleeding and enhances the progesterone effect, enabling a lower dose of the progesterone. While the progesterone, mainly, it suppresses the release of LH from the pituitary, helps in inhibition of the ovulation. Thickening of the cervical mucus impairs the transport of sperm through the cervix to the fallopian tube, and also it promotes the atrophy of the endometrial secretory glands and other changes to the endometrium, causing the endometrium to have an unreceptive mode to the implantation. Now, moving on to its failure rate as well as the effectiveness of the combined oral contraceptive pills with typical use. So how effective are the COCs with typical use? So there is something called perfect use and typical use, which will be coming in short time. So of the options are 92%, 95%, 99%, and 100%. So with typical use, it is 92%. So the oral contraceptive pills are 92% effective with typical use. Now, what is typical use and what is perfect use? Perfect use means where they don't have any missed pill, or they don't even change even minutes or seconds in the time taking the pill. They take it at the exact same time of the day, and they don't take any other drugs or any other things which reduce the effectiveness of the pills. And that is what is called as a perfect use. While typical use, which usually happens with most of the reproductive age women, where they might forget to take the pill at the same time of the day, or may take some other medications which can interfere. In that case, it slightly reduce their effectiveness. And but still, with the typical use, the effectiveness of the oral contraceptive pills is 92%. And with the perfect use, the effectiveness of oral contraceptive use is around 99.7%, which means among 1,000 women using the combined oral contraceptive pills over a period of 1 year, 3 might get pregnant. So that is 99.7% effectiveness with perfect use. Now, the effectiveness depends upon taking each tablet regularly and on time. Effectiveness reduces to 92% if not taken as per correct and as instructions and consistently. Okay, as we can see in this table given, it shows that implants have got the lowest failure rate and maximum effectiveness. Now, moving on to the next one. What happens if we miss a pill, or when can we start the combined oral contraceptive pill? So how many days of additional contraceptive cover is required if the oral contraceptive is started on day 3 of the menstrual cycle? Of the options are 7 days, 5 days, 10 days, or we don't have to give an additional cover. So ideally, if it is started within 5 days of the menstrual cycle, we don't have to give the additional cover with any other additional precautions like any barrier methods, or additional protective measures need not be taken if the oral contraceptive pills are started within 5 days of the menstrual cycle. And so within 5 days of the menstrual cycle, that is the ideal time to start the OCPs, and it can give you an immediate contraceptive cover. That means no need for additional protection. But if you start it after 5 days of the menstrual cycle, and additional contraceptive measures in the form of mainly barrier methods like condoms are required for the next 7 days from the start of the pill. If it is started, if the OCPs are started after miscarriage or termination of medical termination of pregnancy or any surgical termination, then it can be started on the same day or even the day after the procedure. In that case also, we don't have to give any additional precautions. If we have confirmed that the urine pregnancy test has been negative, which is usually routinely done prior to the procedure. So what happens if there is a missed pill? If it is a missed pill of only one pill, then whenever or as soon as she remembers that she has missed a pill, she should take the pill immediately, even if the other pill also has to be taken at the same time. So both pills can be taken on the same day, or as soon as we remember about the missed one pill, that has to be taken, and no need for additional protective measures to be taken, or no need for any emergency contraception to be taken. And the rest of the pack can be continued normally and can have a pill-free interval of 7 days as the pack is indicated, and then can start having the next pack after 7 days of hormone-free interval. So if we have missed 2 or more pills of the combined oral contraceptive pills, then what happens if the pill is missed in week 1, that is from day 1 to 7, then have to take the last pill missed? Yes, definitely. Emergency contraception, if there is an unprotected sexual intercourse has happened, yes, it has to be given. Extra protection for next 7 days has to be given. And the 7-day pill-free period can be taken as usual. And if the missed pill of 2 or more happens during the week 2, that is between days 8 to 14, then have to take the missed pill as soon as we remember about it. Emergency contraception, if there is unprotected sexual intercourse, is not required if it is happening in week 2. And extra contraception for next 7 days is definitely required. And the 7-day pill-free period can be proceeded as usual. If the missed pill of 2 or more of the OCP has happened in the week 3, that is between days 15 to 21 of the menstrual cycle, take the last pill missed as soon as we remember it. Emergency contraception, if there is an unprotected sexual intercourse, is not required if it happens in week 2 or week 3, but definitely easy to be given if it is in week 1. And extra contraceptive additional precautions for the next days have to be next 7 days have to be given in week 3. So whether it is in week 1, week 2, or week 3, extra contraception has to be given for 7 days. And the pill, when we remember it, has to be taken, the missed pill. The EC has to be given only if it is happening in week 1. So what about the 7-day pill-free period? If it is happening in week 3, we can omit it and start the new pack immediately. Okay, hope it's clear. So now coming to the next one, which of the following condition is not a contraindication of OCP use? Among the options are history of venous thromboembolism, may it be a personal history or a family history, migraine without aura, ischemic heart disease, stroke, or a history of breast cancer, who is a breast cancer survivor around 3 years ago. So migraine without aura is not a contraindication for OCP, while migraine with aura is a contraindication for OCP. So there is the UK medical eligibility criteria, which usually we follow to know which category each contraceptive method belongs to, depending upon the medical as well as the surgical condition and the postpartum status and other medical comorbidities of the woman. So when we consider the combined oral contraceptive pills, category 4 means those which are contraindicated conditions. So breastfeeding less than 6 weeks postpartum, non-breastfeeding, then less than 3 weeks with risk factors for venous thromboembolism. If she is a smoker and more than 35 years old, more than or equal to 15 cigarettes smoking per day, then it is a contraindication to use OCP. Vascular conditions like severe hypertension, migraines with aura, ischemic heart disease or stroke, diabetes with vascular complications, both micro or macrovascular, deep venous thrombosis, acute or chronic, pulmonary embolism, history or acute, liver conditions like liver cirrhosis, acute hepatitis, severe liver disease, and most liver tumors, or any breast cancers which are presently is there, that is current, or breast cancer survivors within 5 years. These are all category 4 for OCPs, which means these are all contraindicated conditions for OCPs. Coming to about the smokers, if she is not a smoker, then OCPs can be given up to 50 years of age. But if she is a smoker, then more than 35 years of age, OCP is a contraindication. And definitely breastfeeding less than 6 weeks postpartum, it should not be given. So which of the following cancer risk is not reduced by oral contraceptive pill? Among options, ovarian cancer, endometrial cancer, colorectal cancer, breast cancer. So definitely breast cancer. As we just mentioned before, breast cancer, current or within 5 years, breast cancer survivors, it is a contraindication to use OCP for those women. So the benefits of oral contraceptive pills are highly effective contraceptive. With typical use itself, it is around 92%. Reduction in the other the menstrual abnormalities like heavy menstrual bleeding, dysmenorrhea, premenstrual symptoms. Reduction in the cancers, mainly ovarian cancer, endometrial cancer, colorectal cancer. Reduction in the functional ovarian cyst and benign breast disease. Reduction in pelvic inflammatory disease, basically because it increases the thickness of the cervical mucus and reduces the ascent of the infection and helps in reduction of PID. What are the risks of combined oral contraceptives? As it is contraindicated in coronary artery disease, ischemic heart disease, it increases the risk of CAD, it increases the risk of ischemic stroke 2-folds, increases the risk of thromboembolism 3 to 6-folds. Also, There it is told that there is a small increase in the breast and cervical cancer risk also. So there are certain medications which interfere and reduce the contraceptive effectiveness of oral contraceptive pills, mainly the liver enzyme inducers, anti-epileptic drugs like phenytoin, carbamazepine, antiretroviral drugs like ritonavir and nevirapine, antibiotics like rifampicin and rifabutin. What is the most common side effect of combined oral contraceptive pill? It is among the options, headache, irregular bleeding per vagina, vomiting, and breast tenderness. Yes, all the contraceptives, it is irregular bleeding per vagina, especially for the progesterone only contraceptive injections like DMPA. It's the breakthrough bleeding, which is the most common side effect of the oral contraceptive pills and other contraceptives. So most common, it is a breakthrough bleeding, and they can also complain about nausea, headache, abdominal cramping, breast tenderness, increased vaginal discharge, or decreased libido. So what can be done if there is a side effect like bleeding changes? If there is a irregular bleeding, first of all, reassure that it can have a regularization after a few cycles. Maybe after 2 to 3 months, it comes back to its normal, the normal pattern. Reinforce correct pill taking and review missed pill instructions. Ask about other drugs which can interfere with reducing contraceptive effectiveness of oral contraceptive pills. Administer the short course of NSAIDs as well. For amenorrhea, reassure no medical treatment is necessary. If side effects persist and unacceptable to the woman, if possible, switch the pill formulations or offer another method. So these are all lots of side effects which can occur with oral contraceptive pills and its remedies like nausea, breast tenderness, bloating, and fluid retention, mainly because of the increased estrogen level or dosage or because of some other progesterone. In that case, fluid retention can be reduced with the anti-mineralocorticoid activity induced progesterone, which is a drospirenone, headaches, dysmenorrhea, decreased libido, as well as breakthrough bleeding. How to follow up women who's already started on oral contraceptive pills? At one instant itself, after all these contraindications have been ruled out and basic checks are done, it can be given for a continuous stretch of 12 months of supply of oral contraceptive pills. If any concerns, she can review at 3 months and check her blood pressure annually. What is advised to be given for an oral contraceptive user who is scheduled to have a surgery soon? So ideally, we need to stop the oral contraceptive 4 weeks before a major surgery because of the risk of the thromboembolism and with the estrogen component mainly. And during that period, we need to offer them with alternative acceptable contraceptive methods. Recommends the oral contraceptives 2 weeks after the return to the full mobility. Okay, so that's a nutshell about the topic on oral contraceptives from the module.